Perfect. Welcome, everybody. I'm going to be chatting about the benefits of oral immunotherapy. Thank you so much for joining. I thought we'd start off with a question for the audience, just to understand a little bit about yourselves and how to frame the next 30 minutes. We're going to try a poll. So really to understand if you all have undergone oral immunotherapy or are thinking about doing oral immunotherapy for you or a family member. I believe this is anonymous. Is that right, Tina?
I think I put not anonymous. So
okay.
So everyone's already logged in, registered. So I mean, they're already answering as themselves.
Okay, perfect. Should I go on, Tina? And then you can
show us. Do you want me to share the results or you want
that'd be great.
Yeah, I can share the results. There you go, Sharon. Do you see it?
Yeah, that's wonderful. So a handful of you have undergone oral immunotherapy with us at the center. So welcome back. You may recognize some of the studies I'll be talking about. A handful have undergone oral immunotherapy in the Bay Area and some outside of the Bay Area. Thank you for joining us. And then the majority are interested in learning more. So I really want to encourage everybody to ask questions, because this is really for you, and to share some of the exciting things we've been doing at our center. So without further ado, I'll get started. I have a number of slides. Please ask questions. Let's see here. So I think most of you know the current therapy for most food allergens is avoidance. However, accidental ingestions are common, and a first-time diagnosis of food allergy can cause a reaction that means a trip to the emergency room. So this is emergency room data actually pulled from insurance companies, where we see that over the course of years from 2010, and this data is up to 2016, that the rise of there's been an increase in the amount of emergency room visits, and not only for anaphylaxis to foods, but also to other causes. And when we take a closer look at what foods are causing trips to the emergency room, we see that peanuts are the most common, followed by tree nuts and seeds, eggs and milk, and fish and shellfish. We have, in the last decade or longer, been studying different treatment options for food allergy. The most commonly studied is oral immunotherapy, which I'll spend a lot of time talking about today. And we are very grateful that we have one FDA-approved therapy for peanut allergies for children. I'll talk a little bit about that today too. So changing the landscape with oral immunotherapy, what that means is we are taking the food that you're allergic to in small amounts, dust size particles, and then building that up so that we can introduce this to your immune system in a careful and a precise and monitored setting, so that we can get you to a point where you could actually tolerate a serving size of the food that you are allergic to. And a serving size of milk would be a glass of milk, which would be 8 grams of that protein in a glass of milk, or a handful of peanuts, which might be 16 to 20 peanuts. And we've done that, and I'll share some of that data with you today. But the question is that what is the right amount to target? So there's many questions that remain in the field, but we're very lucky that we have the first generation of therapy, which is oral immunotherapy. And I'm going to talk a little bit about the benefits and some of the downsides of oral immunotherapy, hopefully to have a very frank conversation here. These are souffle cups. So when you come to our center, this is how we measure it out and precisely quantify the proteins that are in this food flour. If this were to be walnut, for instance, or hazelnut, we know exactly which of the allergens in hazelnut we're quantifying and measuring in our lab. We send out this food flour to other labs to make sure there's no cross contaminants, there's no microbes, yeast, molds, etc. So we are really careful about the product that is considered a drug in the eyes of the FDA in these clinical trials to make sure that we can quantify the amount of protein and that it's a healthy substance that we're asking you to ingest. And over time, we're able to go from, like I mentioned, dust to larger quantities in a stepwise fashion in a very careful, monitored setting in our research unit. I'll talk a little bit about oral immunotherapy. So this is the pivotal study. It's a phase 3 study. What that means is a phase 3 study is really testing the safety and the efficacy of the treatment. And this is Palforzia. So this is the drug that is currently approved for 4 to 17-year-olds with a peanut allergy. This phase 3 study looked at almost 500 kids and randomized them to receive peanut, which is the AR101, which you'll see here in the blue bars, okay, or placebo, which is these lighter blue or gray bars, and built up these participants in the clinical trial to get to a dose of 300 milligrams or roughly one peanut. So one peanut kernel here over the course of 6 months, and then asked participants to maintain 300 milligrams of peanut or placebo for another 6 months, and then do food challenges at the end of that. That's what I'm showing you here in this graph. And what you see here is that 75 to 80% of individuals were able to tolerate 300 milligrams at that 1 year food challenge compared to very less than 10% of placebo. And then 65% roughly were able to tolerate 600 milligrams by taking 300 milligrams for over the course of a year. And actually a little over 50% were able to tolerate 1,000 milligrams, which is really exciting and interesting. And what it really shows is that you can maintain at a dose, and then there's some wiggle room that you could actually tolerate more at a food challenge. The most common side effects were GI side effects, which I highlight here. So this is the Palisade study, the phase 3 study that I was just showing on the other slide. This is during the initial food introduction, the updosing portion to get to 300 milligrams, the maintenance portion, and then overall over the course of the study. And what I really want to draw your eyes to is the GI side effects, which are the most common side effects of oral immunotherapy. Often they are very mild. But it is very common, and those who do oral immunotherapy have kind of tricks up our sleeves to get participants through this. Many participants are able to get through these little bumps in the road, but some it really affects their lifestyle and can be intimidating, especially if it's not expected. And in this study of 500 children, it led to the withdrawals 12% almost in the peanut arm versus 2% in the placebo. I'm seeing a few questions. What impact does age have on OIT, if any? And does it decrease effectiveness in older patients? That's a fantastic question. We have studied, and I'll show you in the next slide, the POISE study, where we looked at desensitizing peanut allergic kids and adults age 7 to 55. And we have not seen that age makes a difference in desensitization. And it's a matter of really sticking with it. So the Palisade study did actually study adults as well. And this was done over numerous sites across the country and worldwide, actually, internationally. But the adults had a lot of dropouts. And so they did not report that data. I think almost half of the adults who were enrolled in the study dropped out. And that's due to many things, not just side effects from oral immunotherapy, but also kind of the time commitment that's involved in doing something like this. The next question is, what GI side effects, in particular EOE, have you done? What have you done to mitigate it? It's actually, this is a fantastic question. It's really hard to make a diagnosis of EOE because it is a diagnosis that is about clinical symptoms and biopsies from the esophagus, where we see greater than 15 EOs per high-powered field. So many patients who undergo oral immunotherapy don't go on to get endoscopy, even when we refer to our GI colleagues. And we at the center have established wonderful relationships with our GI colleagues to be able to funnel patients quickly to their clinic and to their care for their evaluation to understand if somebody has EOE. The very reassuring fact is that there are many patients that we can get through the abdominal pain or the nausea feeling with some careful algorithms that we've worked through at the center. And for those that have persistent abdominal pain, we have an algorithm. But most of those patients, if you were to stop oral immunotherapy, the GI side effects go away. So they are not persistent. And even if those patients continue on oral immunotherapy, if we decrease the dose, if we add some acid blockers for a brief period of time, we're able to get to a point where the immune cells in the gut can come to some balance, and we can get patients over this hump. But we have thresholds where we say, okay, this is enough time. We've tried a number of steps where we then bring in our GI colleagues. And so we've worked out this algorithm over many years of doing oral immunotherapy in our center. So these are some of the things, barriers to implementing oral immunotherapy on a larger scale, safety side effects like we're talking about, anxiety and compliance, which is a huge piece. And we're very fortunate to have a therapist on our team. We can refer participants to. Former trial participants also are a great resource for families that are currently going through clinical trials. And duration of therapy is the question of how long do we have to do this to maintain benefit or effect. So to tackle this question, can desensitization last? If we test how well the food allergen is tolerated in the long-term follow-up periods of daily oral immunotherapy, does the patient maintain the same level of desensitization? We saw a hint of that in the Palisade study where we maintained for 6 months, and they were able to actually tolerate 50% were able to tolerate 1,000 milligrams or 3 peanuts. But what about if we test for withdrawal to the food allergen after a period of oral immunotherapy, what we called sustained unresponsiveness? Here, the numbers vary depending on what food we're talking about, egg, peanut, milk, and what period of avoidance or withdrawal we're talking about. And it ranges somewhere between 20 to 55%, as you can see here. So that brings us to our POISE study. And I think some on the line may have been involved with this study or know this study well. This was a large phase 2 randomized control trial looking at 120 peanut allergic kids and adults. This is looking at the desensitization process where, we do food challenges in the beginning to peanut or placebo. We randomize people to one of 3 arms. I'll get into that in a moment. We build them up to 4 grams of peanut or placebo. To put that in perspective, 4 grams of peanut is 2 tablespoons of peanut butter, or about 16 to 20 peanuts, which is amazing. Then they maintain 4 grams of peanut or placebo every day over the course of the second year. And then this is really where we get into tolerance testing, trying to understand the long-term consequences of desensitization. And here we decided to test not only can you stop peanut, but what if you decrease the dose to 300 milligrams, roughly 1 peanut a day? And that was based on feedback from our community, from people like you, who in our phase 1 study said, you know what, to get my 5-year-old to eat 16 peanuts a day is really tough. And if we add on, 3 other allergens, that's more than a meal. So can we get by with a little bit lower? So we really took that to heart and tried to build in this third arm of testing whether 1 peanut a day could maintain the same level of desensitization. And then over the course of this third year, we did food challenges every 3 months, up to 4 grams of peanut, to understand how the immune system remembers, whether or not somebody is going to have allergic reactions to 4 grams of peanut. So the 3 different study arms, that's not showing up well, were this first arm where people build up to 4 grams of peanut and then go on to avoidance. We call that the peanut zero arm. The second arm was people build up to 4 grams of peanut and then drop to 300 milligrams of peanut, or the third arm where they were assigned to placebo and remained on placebo even in that third year of testing. Oh, there we go. So these are the results. We looked at that first time period, that first 3-month interval of avoidance or change in therapy, that week 117 food challenge. And what I'm showing you here is this was our primary endpoint for the study, and 35%. So a third of those patients who went on to avoidance were able to still not react to a 4-gram peanut food challenge, which is remarkable. 54% of those who dropped their dose down to 300 milligrams were able to still tolerate 4 grams of peanut, which is really quite amazing, compared to 4% in the placebo arm, who were able to tolerate 4 grams at the end of the desensitization maintenance period of peanut, and then still were able to tolerate 4 grams of peanut after continuing on with placebo. And what we see here is that over time, we're looking at, the end of the peanut buildup and maintenance time, and then we're looking at the 3-month food challenges. And let me tell you, this was really amazing of our families to stick with us and do these every 3-month food challenges. We are so grateful for all of the families that participated in this study, because this was the first time we had data on 1-year long-term treatment options of avoidance and of dropping the dose. So the gray bars are placebo. The blue bars are the participants who dropped down to 300 milligrams, the 1 peanut. And the gold bars are those who avoided for a year. And you can actually see the gold bars out for a year. So after they had been on 4 grams of peanut for 2 years, 1 year later, 13% of those people were still able to tolerate 4 grams on a food challenge after a year of avoidance, compared to 37% of those people who had been taking 1 peanut a day after a year of decreasing their therapy. And for this study, there's nuances to it. Here I'm also showing you that's 4 grams of peanut, but there's many people who could tolerate much less, which was still much more than when they started But our study defined 4 grams as kind of the benchmark that we were really testing. 2 tablespoons of peanut butter, 16 to 20 peanuts, which is really a high bar. And what this shows us is that, we need good biomarkers to help us understand and predict who these 13 and 37% of folks that have peanut allergies are, so that we can make that decision at the beginning of the study. We were able to see some sense of that in some of the blood tests that we did, and we're really looking into that a little bit deeper. Safety is paramount and should be part of any study testing for a cure. And really here I'm showing you, this is year 1, year 2, year 3, peanut versus placebo. What I really want to just draw your eyes to is that over time, the amount of epinephrine injection use decreases over time. The reactions to an accidental ingestion of peanut decreases the longer you're on therapy. There were allergic reactions due to an unknown culprit, maybe peanut, maybe another allergen, which is really hard to characterize. The other important part of safety is really instructing patients and research participants with a written instruction plan. And this is a nice study done with one of our colleagues and collaborators, Stefania Rossi, in Italy, that said that if we give people the proper information, written instructions, that can really reduce the risk of an adverse reaction during the maintenance phase of oral immunotherapy and still maintain the beneficial effect of the treatment. How do we make this safer? How do we improve on this? This is a very complicated slide. Let me just take a moment and pause and see kind of what questions we have here. Let's see. At SNP, do you conduct only clinical trials? Yes. Our research center conducts clinical trials. Our allergists have clinics as well. And within Stanford, we are able to do Palforzia for peanut oral immunotherapy. And then we have clinical trials for other foods and multi-allergen foods. Let's see. Are respiratory side effects another term for anaphylaxis? That's a great question. Anaphylaxis is a very broad term for an allergic reaction that involves 2 organ systems after you know that somebody's eaten the food. And so it could be that you have a few hives and some nasal congestion, and that would be anaphylaxis. Now, that would be mild anaphylaxis. Sometimes the clinical trials or the studies have their own definition of anaphylaxis, so that's kind of important to tease out, because what's more worrisome are the more severe anaphylaxis where there's respiratory side effects like wheezing or can't breathe. Any behavioral issues seen in children undergoing oral immunotherapy? I don't know that I would say behavioral issues, but there's a lot of anxiety in our food allergy community, which we know about and totally understand. And that's frankly very normal because there's a lot of anxiety about ingesting food. And so you can imagine that it's hard to wrap your head around as a 7-year-old, as a 12-year-old, as a 17-year-old, as a 41-year-old, that we're now asking you to eat the food every day that you've been told all your life to avoid. So our team does a really good job, I'm biased, of course, of trying to address that anxiety, provide a safe place where people feel like they have access to the research team, to our clinicians that man a 24/7 on-call phone line to be able to respond to anybody who has questions when they're dosing at home, when they're in the clinical trial. And really that's to provide another kind of safety net anchor and resource for our research participants that are going through this and who may have struggles or questions when they're at home and dosing after the workday, and really trying to understand and provide a resource to make sure that patients who are going through these trials feel safe, feel like they have somebody they can reach out to who's an expert to offer advice. What's the distribution of peanut IgE in the study? Would it work for someone with high IgE level over 1,000? That's a fantastic question. And so we have definitely seen that desensitization can work for any IgE level. And that side effects are not necessarily linked to your IgE level. And the higher the IgE is for a specific allergen, what that tells us is that it's most likely to be a true allergen. There's some instances where patients come in with positive IgEs and then undergo a food challenge to see if they can enter into a clinical trial and then don't react. And in those cases, sometimes those IgE levels are low, and these tests are not perfect, and sometimes there's some false positives, and we're very happy to then say, hey, you may not actually have a true food allergy to almond, even though your IgE was 1.5. And those are conversations you should definitely have with your allergist, and if we're happy to see some of those individuals in our research unit and give that news, then we are always happy to communicate with your own allergist to make sure that they have all of the results to make good decisions and give advice about those foods. What's the risk of EOE based on the study? Do we know the risk factors for EOE? That's a fantastic question. We don't know the risk factors for EOE. In fact, it's a mixed immune reaction, more T cell driven. We don't have great tests for EOE except for elimination diets. One person in our HOI study developed EOE. They stopped dosing with oral immunotherapy. Their symptoms resolved. They had another endoscopy, and the EOs also went away from the esophagus. I am I know we only have a few more minutes. I just wanted to touch base here. Some of your questions are fantastic and actually leading me into the next part of the talk, which is the next generation of food allergy treatments, which we're doing at our center, are really targeting the immune cascade here. So these are all immune cells that lead to the allergic response. These cells dump out cytokines, which really help promote the allergic reaction. And what's fascinating is that we've come so far in drug discovery, we can actually block parts of these allergic reactions. And so that's what we've been studying here. Anti-IgE, you guys will maybe recognize IgE as, our IgE skin tests, our IgE blood tests. There's targeted drugs that actually target IgE. We've done a lot of studies with this with omalizumab. We'll be doing a study with ligelizumab coming down the road, and some of these other drugs as well, dupilumab, for instance, and some other exciting drugs. I'll skip over some of these slides. We did do we've done a few multi-food oral immunotherapy with biologic studies. And we've done it multi-center. So we actually shared our protocol with 6 other sites across the country that led to the publication of our MTEX study. We also had a MAPX study that was done at Stanford. And I'll skip to here, which is really that this study looked at people who had food allergies to 2 to 5 foods, and we simultaneously desensitized them to 2 to 5 of their foods that they were allergic to, using a combination approach of mixing the allergens and also combining that with a short course of anti-IgE called omalizumab. And what you're seeing here is at the end of almost 9 months of therapy, 36 weeks, what you're seeing here is that those folks who received omalizumab plus multi-allergen oral immunotherapy, 96% were able to pass a food challenge to 2 grams or larger or more. 83% were able to pass a challenge to 2 grams. For 4 or more foods, 91% passing for 5 foods, compared to those people who received placebo injections plus multi-allergen oral immunotherapy after a period of 6 weeks of avoidance. So we desensitized them using this combined approach, and then tell them to go off of therapy for 6 weeks, and then tested them again with food challenges. I will skip over this slide, and I will say that we have many studies at our center using a combination approach and for patients with multi-food allergens. In fact, about 70% of the people who come to our research center have an allergy to more than one food. So this is not uncommon. But the work that we've done at Stanford, we've been very proud and very happy to share with other sites. This has led to a phase 3 study with the NIH that's sponsored through the Consortium for Food Allergy Research. This is our Outmatch study. We're currently enrolling for this study, and we have trained 9 other sites who are also participating across the country. Why do we do this? We recently have this actually accepted for publication, hasn't come out yet, but really we're partnered with our community, with folks like you, and what you've told us is that your quality of life is improved with oral immunotherapy. And I'll share some quotes from members of our community. Michelle, who's 15, I recently ate a slice of my dad's birthday cake, which accidentally had nuts, something that previously meant a hospital visit. I did not react. My sense of relief quickly became a sense of gratitude for Dr. Nadeau and her staff. I no longer live my life fearing a food allergy reaction. Instead, I can use this positive energy to fully develop my abilities and pay forward the kindness shown to me. Sinclair, 18, I was diagnosed with a peanut allergy as a baby and have had many visits to the emergency room. When I was a sophomore, I started mountain climbing. I feel like the team at the center is with me on my climbs. In 2016, I climbed Aconcagua in Argentina, the tallest mountain in the Western Hemisphere. Even in the high winds and sub-zero temperatures, I took my daily dose of peanuts throughout the trip. And Oliver, 7, it was a dream come true to be part of the study and to meet and work with Dr. Nadeau and her team. Oliver's life and ours, by extension, has changed in such a positive way since he has overcome his allergies. We cannot ever thank you and the team enough for your kindness and care and amazing expertise. Congratulations on the success of the study. I know that we've kind of run out of time, but these are some of our open studies. We are really pushing the envelope for the next generation of food allergy therapies. We've got different foods in the mix here. A few multi-food studies, studies that are for milk or peanut or shrimp or cashew. We're using digital technology to incorporate that into our food allergy studies. We're doing a food equity initiative where we're trying to help and educate food allergy families that don't have as many resources. And we have a birth cohort study that recently just started to understand the development of food allergies. And then a prevention study looking at infants with eczema and trying to see if we can prevent the development of food allergies. So we're understanding disease and mechanisms and opportunities to intervene in food allergy from pregnancy and beyond. And with that, I'll stop and I'll leave it there. Thank you so much for your time today. I'm sorry I couldn't get to all of the questions, but I will try to get back to you. Our team will try and get back to you for those questions that we were not able to answer live. We're happy to see you in our research center for an initial consultation to see if we can answer your questions. We've got a lot of very interesting and novel protocols. Most of our protocols actually have a therapy arm And we're very excited to be working with you to change the future of food allergy.
Thank you, everyone. Please feel free to email snpallergy@stanford.edu if you have any other questions. I've saved all the questions that I have from the Q&A panel and from the chat. So I'll be sending that to Dr. Chinthrajah to answer through email. So thank you so much again. Any last words, Sharon?
No, thank you so much for your time and attention today.